Okay, hello, welcome to Health Careers Live. My name is Luke Austen. I'm currently a CT2 trainee doctor in anaesthesia and intensive care medicine. And today I'm going to be talking about how new doctors, and indeed any new healthcare professionals entering a profession at the early stages of a career, can get things right for their patients. Particularly, we're going to be looking at some psychology and some clinical thinking and analysing how we make decisions as young healthcare professionals. We're often presented with images of new doctors recently qualified from medical school, such as this one. Look at them, all happy and confident, freshly purchased stethoscopes hung around their necks, brimming with clinical knowledge gained from the last 4, 5, 6 years of medical school, ready to go out onto the wards and face the challenges of the day. In fact, reality, I think for many of us, is more like these pictures here. Sometimes we might feel afraid, a bit frightened, lonely, unsure, anxious, puzzled, not knowing what to do, and needing to call a friend for some help. So we have this formal pathway of escalation, seeking help from our more senior colleagues. And in the NHS, you've got your most junior doctors who are the FY1s and the FY2s. But internationally, this might be, the intern or the junior resident. And when we don't know what to do and when we're struggling within our own team, we seek help from the senior colleague who is the registrar. And they will either give us a plan or some advice for the patient and help us work out what we should do with this particular clinical decision. Or if the issue lies outside of our own specialty, it's in a different domain and we need help from a different team, they'll help us to do a referral to a registrar from the second team. Or if they're really helpful, they'll do the referral themselves. If the problem is seriously difficult and complex, and even the registrar is struggling, they can escalate themselves and we can ask for help from the consultant. And similarly, the registrar from the second team may also ask for help from their own consultant. So this is a traditional pathway of escalation and referral in healthcare teams when we're struggling with a complex clinical problem that is challenging for somebody newly qualified at the start of their career. It works on this assumption that however difficult and fatigued we are finding things, things will always be okay, because if you don't know, just ask. It reminds me of a famous assertion from this gentleman here, who in Hagrid's hut, towards the business end of the Chamber of Secrets, famously said, "Help will always be given at Hogwarts to those who ask for it." But hospital is not Hogwarts. And there are a few problems with this traditional model of escalation that we need to think about. We may find, given the immense pressures of work and clinical overwhelm in the service today, that our immediate senior help is either unavailable or unresponsive, or unable to attend within the required time frame to help the patient. It may be the case that the pace of deterioration in a patient's clinical condition outstrips the pace with which we are able to seek the required senior help, and we need to have a plan B. This is sideways escalation, where we immediately seek help from an alternative team, going to a different registrar ourselves, perhaps calling the nurse site manager if the problem is something they will be able to help with, a critical care outreach team made up of senior critical care nurses with years of experience who can come to the ward to assist, or even taking the ultimate sideways escalation step and putting out a crash call for a medical emergency team to immediately attend to the patient. However, there remains a more fundamental problem with the assumption that if you don't know, just ask. What if we don't know that we don't know? All of us have blind spots. This is the Dunning-Kruger curve, which is a classical diagram from psychology published in 1999, where on the x-axis we have competence, and on the y-axis we have confidence. Towards the far left-hand side of the diagram, you can see what's described as the peak of Mount Stupid, where we're ignorant and unaware of it, when we truly are not very competent in a particular domain, we may have so little insight into the complexities and demands of that clinical challenge that we have not appreciated how difficult it is. So we are inappropriately overconfident in our ability to deal with it. Here, ignorance is not only bliss, it is also blind. In the middle of the diagram, we've begun to know enough to realize how much we don't know. Indeed, this may be the purpose of medical school, that over those years of training, we begin to increase in competence such that we have understood how difficult the problem is and will appropriately seek help at an early stage. And then for the rest of medical training is a much more linear, smooth progression on the path towards mastery, where confidence gradually increases again as we gain in competence. So we need to know where these blind spots and these issue of blind spots fits in. And to do that, we've got to think about how do doctors think? This is Professor Jerome Groopman from Harvard's famous book from 2007, which shot to the top of the New York Times bestseller list, called How Doctors Think. But for our purposes, thinking about newly qualified healthcare professionals, we need to think about how do junior doctors think? In 2017, a GP trainee called Emily Adams published this research study along with a group from Oxford, where they conducted qualitative interviews with doctors of 2, 3, or 4 years experience working in the emergency department, which is a very challenging domain for clinical reasoning because of how sick the patients are and the fact that they're undifferentiated. At that early stage in the ED, we just don't know what's going on very often. So they sat these junior doctors down and got them to talk through some cases, and then using the data and the recordings of those interviews, began to draw out some themes about how they were thinking, and use that information to begin to construct a model. Some of you may have read Thinking Fast and Slow by Daniel Kahneman, which describes his theory of the dual cognition theory, a system one of quick, rapid, intuitive thinking, of making fast judgments based on years of prior experience, pattern recognition, versus a system two, thinking slow, of using careful, slow, structured analytical reasoning. And the model that this group came up with accepts Kahneman's dual cognition theory as a basis for their model. So here we go then. So the first thing that junior doctors tended to do was something called case framing, an initial rapid review of the referral letters, the triage notes, or an end of bedogram assessment of how the patient looked. Did they look well or did they look sick? And decide whether to go into resus mode, call for help and take the patient to the resuscitation room, or continue in standard mode with their usual medical evaluation. Initially, they used a thinking fast type process to see whether they had pattern recognition and could understand immediately what they thought was going on. For example, if the patient presented with central crushing chest pain, nausea, sweating, vomiting, and the pain radiating down the left arm, and they had a background of heart disease, high cholesterol, diabetes, and smoking, the pattern recognition would suggest that the patient was having a heart attack. So if the junior doctor thought that they recognized what was going on, they proceeded to use some red flag questions, some rule outs, have a diagnostic timeout to just stop and think. And if they were still happy that the pattern was fitting with their initial recognition, they would progress to the decision threshold. However, if initially they had a reaction of non-recognition, they would switch over to a different method of thinking slow, breaking up the patient's presentation into the different symptoms and using rehearsed question sets, the set of back pain questions or chest pain questions that you're taught to ask at medical school. If at the checkpoints somebody had initially thought they'd recognized the pattern, but were then met with some new information which didn't quite fit, giving the reaction of pattern non-fit, the doctors then switched back round and proceeded to continue with as though they'd had a reaction of non-recognition and used the thinking slow method. Now, if after thinking slow, they thought they had the answers, they would progress to the decision threshold. But otherwise, if there was still some uncertainty, they would expand the clinical encounter, either doing some more tests, allowing some more time for the situation to develop, or seeking help from a senior doctor to share the responsibility, that process of escalation. And then eventually the decision would be made. So it's important to recognise that our blind spot bias can affect us at multiple stages of this thinking model. We may initially be blind to how sick the patient is and not quite realise just how unwell they are and how rapidly we need to seek help. We may have blind spots that sort of draw us into thinking that we recognise the pattern, that we think we know what's going on, when in fact we are mistaken. We may think that the pattern still fits after our questions and be mistaken. And equally, even after that slow process of reasoning and thinking, we may still be blind, and it may be a clinical presentation that is outwith of our prior set of experiences. So, how can we see when we are blind? What can we do to try and mitigate these risks as newly qualified healthcare professionals? This is another diagram from psychology, which is called the Johari window, which divides information up into 4 domains. In the initial study, they got participants into a group and asked them to look at adjectives or descriptors and decide whether or not they thought those words applied to their own personalities and to the personalities of their peers in the group. Now, if both the participants and their peers had selected those words, they went into the top left-hand box, which is the arena, descriptors that were known to the self, but also known to others. Now, if those words were selected by yourself, but not selected by your peers, that was called facade. Now, if it was words or descriptors that the person had chosen about themselves, it was information that the peers had chosen and it was known to them, but the individual had not chosen about themselves, that was the blind spot on the part of the individual. And finally, if there were words that neither party had chosen, either because neither party had recognised they were applicable or because they truly did not apply, that was the bottom right-hand corner of the diagram, the unknown. Similarly, clinical information can be put into these 4 categories. And it is the information which is known by both ourselves and by the team around us, be that the nurses, dietitians, physiotherapists, site managers, or even the patient's family or the patient themselves. That shared information in the top left hand of the diagram in the arena is the truly useful and actionable information and forms the basis of the shared mental model, which we often hear about in the human factors literature. So for this reason, we need to try and make the arena as big as possible and make that arena portion fulfill as much as we can of the diagram. How do we do this? We can share the information that we have. We can share our own perceptions and information we have gained from speaking to and examining the patients with the rest of the team, bringing that information to bear. That is information sharing. We can seek feedback to try and reduce our own blind spot bias. We can ask those around us, what am I not seeing here? Is there anything that I'm missing? What do you think? Especially when we are newly qualified, either as newly qualified nurses or doctors, starting out in the healthcare professions. Those senior professionals around us will have years of experience and wisdom to offer. We can seek feedback from them and reduce our blind spots. Finally, we can do some investigations and examinations to try and reduce the size of the information that is truly unknown. In this way, we can expand the arena of information that can help with our clinical thinking and clinical decision making. You'll remember that we spoke about those 2 modes of thinking fast and thinking slow. Both of them are important, and part of the skill, if there is one, is realizing and recognizing which mode of thinking we're using and which one is appropriate at a particular time in the hospital, based on the clinical situation in which we find ourselves. However, it's also been shown that blind spot bias, how difficult we think a problem is, whether we think it is really simple or whether we think it's actually really difficult, itself affects the mode of thinking and the mode of reasoning that clinicians employ. This was a study by Mahmood and colleagues in 2008. we found that the influence of the perceived difficulty of a case affected the physician's diagnostic reasoning. They took 10 medical cases and presented them to medical interns. These are quite challenging cases to identify and diagnose actually. And they split the cases into 5 and 5. For the first 5 cases, an intern was told nothing in particular. They were just presented as standard medical cases to solve. But for the second 5 cases they were told that a consultant had failed to get the diagnosis, therefore inducing a perception of complexity. And when you had this artificial perception of complexity, the researchers showed that the trainee doctors switched over to that slow, more careful, analytical reasoning, which in junior professionals is known to be safer, because the studies have shown that in newly qualified and younger healthcare professionals, trying to think fast and reach intuitive, rapid judgments is often flawed and is error prone. So thank you for listening to this short presentation today at Health Careers Live. I hope it's given you a flavour of some really interesting topics about clinical thinking that are relevant to all healthcare professionals. It's something I've written about quite a bit in my book, The Bleep Test, which also covers other issues, including making mistakes at an early stage in our career, learning from getting things right, working at night with extreme fatigue and decision fatigue, looking after patients at the end of their lives, and coping with the challenges of work and our own mental well-being. If anyone does have a chance to read it and would like to get in touch, you can talk to me on Twitter or send a message via the website. In the meantime, I hope you have a great day for the rest of Health Careers Live.